Next session by Dr. Jasjeet Mazid was taken in the morning because he had to leave. So the session to be followed now is multifactorial approach in type 2 diabetes management, evidence with once weekly GLP-1 RA dulaglutide. So the speaker is Dr. Saket Kant.
I think we can start the session, sir.
All right, thank you very much for that introduction. And what I'll be taking you through after we had a discussion on the RSSTI field is the multifactorial approach to type 2 diabetes management. Now that we have moved away from a glycemia-based approach to a more holistic pathophysiology-based approach to type 2 diabetes, managing the comorbid conditions and lessening hypoglycemia plus decreasing glycemic variability also. This is the holistic multifactorial approach to management of type 2 diabetes. You've got a lot of complications in type 2 diabetes that are beyond glycemic control. Glycemic control is one part of the total picture. We know that patients with diabetes are 2 times higher risk of developing CVD compared to people without diabetes. And we get CVD 10 years earlier, and mortality, morbidity, in fact, would be higher in Asians, especially Indians, with type 2 diabetes, and the risk starts to increase in the pre-diabetic phase itself. So we have to improve glycemic control, prevent microvascular complications. We have to minimize CVD risk factors to reduce the events, cardiovascular events and mortality. If you look at the benefits of interventions, you can see systolic blood pressure reduction by 4 millimeters would reduce cardiovascular event by around 12.5%, LDL reduction by 28.2%, and you have an A1C reduction of 0.9 that would reduce cardiovascular events by 2.9%. But combined, you can get an even better benefit for all these. You have to have a multifactorial approach to diabetes management. This is what Steno-2 trial did. In addition to glycemic control, you have to manage dyslipidemia, blood pressure, have to have lifestyle modification in all your patients, and you can have platelet inhibition also. So it is not only A1C, not only fasting postprandials, you have to go beyond these to manage complications in type 2 diabetes. And this is where GLP-1 receptor agonists come in. You have the glycemic and the anti-atherosclerotic benefits of GLP-1 receptor agonist. The glycemia is improved because they are GLP-1 receptor agonists. They would increase the insulin secretion from the beta cells, decrease glucagon by a paracrine action. They increase beta cell proliferation, decrease beta cell apoptosis. The hepatic glucose output is decreased. There is decreased gastric emptying. On the brain, direct action by decreasing appetite, and there is decreased adiposity also. The important thing that these drugs can do, and that is the reason these drugs in the guidelines have come up very high for patients with ASCVD or multiple risk factors for ASCVD, are that they can cause a reduction in the atherosclerotic plaque by decreasing the absorption of decreasing ApoB48, decreasing free fatty acid secretion, increasing nitric oxide reaction, decreasing reactive oxygen species, decreasing inflammation in the endothelium. The smooth muscle cell proliferation is decreased. So all of these adds to the anti-atherosclerotic plaque effect that these drugs have. Look at the guidelines, 2022 recommendations by ADA, stratification according to the risk factors that the patient has and the comorbid condition that the patient has. ASCVD, GLP-1 receptor agonists are up the ladder if the patient does not want an injectable or the cost is an issue. Now that we have semaglutide also, but if that is an issue, SGLT2 with proven CVD benefit has to come up. Heart failure, it has to be an SGLT2. CKD, it has to be an SGLT2 again. The other things that have to be looked into is minimizing hypoglycemia, minimizing weight gain or promoting weight loss, and cost is an important component because most of our patients are paying out of their pockets. So whenever you're looking at an injectable, now that we have oral GLP-1 receptor agonists also, they should be preferred to insulin when possible, but that does not mean that all patients who need insulin can be shifted to a GLP-1 receptor agonist. Patients who need insulin, but you have to choose your patients wisely when they are planning to start their first injectable. So patients who have ongoing catabolism, losing weight at diagnosis, who have symptoms of hypoglycemia, polyuria, polydipsia, who have A1C of more than 10, blood glucose random more than 300, or wherein you have a diagnosis of type 1 diabetes, LADA, or pancreatic diabetes, a possibility, that is a time that you should initiate insulin for your patients. But if GLP-1 receptor agonist has to be considered, if the patient is obese, you want a good HB1 lowering efficacy, you have patients with ASCVD, multiple risk factors for ASCVD, and the frequency of injection has to be reduced, then you can choose a GLP-1 receptor agonist. A once weekly dulaglutide would manage a lot of pathophysiology of the omnisoctard. If you look at glycemic control with dulaglutide and you compare it with liraglutide, I would not appreciate comparing it with insulin, because insulin is something different as compared to what GLP-1 receptor agonists are. But comparing it as an add-on to metformin versus liraglutide, almost equal reduction in A1C with the 1.5 dula, that is the highest dose of dulaglutide, and liraglutide 1.8 milligram. Weight loss in the various trials, you can see 3.61 kg weight loss. But what we see in trials, I guess most of us would have observed much higher weight loss when combined with lifestyle modifications. And we have seen weight loss up to 10 to 12 kg in our patients. Comparing the CVOTs of GLP-1 receptor agonists, lot of CVOTs, liraglutide, semaglutide, lixisenatide, exenatide, dulaglutide, albiglutide, semaglutide, Pioneer 6, with subcutaneous and oral Sustain 6, and amplitude which is not available right now. You look at the rewind data with dulaglutide, you can see 10,000 patients. Secondary prevention established CVD, the reduction was 31.5%. The patient number was around 31.5%. Primary prevention group with risk factors of CVD was 69.5%. 46% women, 5.4 years follow-up. That is the largest that you have with any GLP-1 receptor agonist trial. And the mean eGFR was around 75 to 80 in all the trials. So there was the primary composite outcome, 3-point MACE. Leader had 13% reduction. Sustain 6 has 26%. Rewind 12%, Harmony 22%, and Amplitude had 27% reduction. With Alexa and Excel, there were no reductions. Non-significant. Pioneer 6 also did not have a reduction. Pioneer 6 is with the oral semaglutide. So the GLP-1 receptor agonists that showed benefits in major adverse cardiovascular events were liraglutide, semaglutide injectable, dulaglutide, albiglutide, and the glutide that is not available. We probably will be having this very soon. So once weekly dulaglutide was reducing the relative risk of 3-point MACE by 12%, despite majority of patients not having established CVD. Now this is important because we know higher the risk, higher is the benefit, but patients who did not have established CVD, low risk patients also responded by a 12% reduction, that is good. The median follow-up was 5.4 years, but the benefits started to accrue just about after 1 year. So whenever you plan to start a patient on dulaglutide, this is what you have to talk to your patients. The patient is going to ask, look, I'm going to start an injectable therapy dulaglutide for me, but for how long would I be taking this medication? So that has to be told to the patient itself that if you want to accrue the cardiovascular benefits, it has to go beyond 1 year. Less than 1 year, the benefit would not be there. So it has to be more than 1 year that if you want to start, will have to continue for more than 1 year. It is the first and only GLP-1 receptor agonist, both primary and secondary prevention in type 2 diabetes. Major adverse cardiovascular events, non-fatal MI, non-fatal stroke, cardiovascular death in adults with type 2 without cardiovascular disease has reduced. So it is both primary and secondary prevention, and it has shown benefits in low risk category also. That is also very important. Adverse effects almost comparable. If you look at the p-values, immune reactions were somewhat lesser with dulaglutide. All the others, serious hepatic events, again lesser with dulaglutide, although p-value was not significant. And the hypoglycemia, I guess it is not expected because GLP-1 receptor agonist would cause insulin release in a glucose-dependent fashion. So hypoglycemia is not expected unless you have a combination of GLP-1 receptor agonist with sulfonylureas, glenides, or insulin. So we do not expect hypoglycemia with these drugs. Look at the rewind data and you see the LDL reduction, also the p-value is significant. Systolic blood pressure reduction is also significant. and there was some increase in heart rate by 1.9 beats per minute from baseline. The p-value was again significant for dulaglutide. The microvascular composite outcome with once weekly dulaglutide in Rewind study, you had a 13% reduction, and that basically showed significance. The p-value is significant. So use of lasers, anti-VEGF therapies, vitrectomies, new microalbuminuria, or 30% fall in EGFR, or chronic renal replacement therapy, the benefits were there and the p-value is significant. The ease of administration, once a week dulaglutide injectable therapy versus daily liraglutide, the injection burden is 87% lesser, and in a survey, 83.1% patient chose a once weekly therapy over a daily injectable. Easy to use pen, the needle is not visible, so it adds because it would decrease the needle phobia for patients. But some things have to be kept in mind. You have to counsel your patient for potential GI side effects, potential nausea and fullness. That is what is expected of dulaglutide. So if you tell them that nausea and fullness basically mean that the drug is effective, the patient is more likely to accept this. So they have to contact the healthcare provider in case they have severe persistent nausea or vomiting, but slight nausea fullness is expected because of the effects of dulaglutide. They should eat slowly. They should consume smaller meals that would reduce nausea. Probably eating at frequent intervals would make more sense. You can have some prophylactic antiemetic agents to prevent nausea, vomiting if the patient are not tolerating, but these drugs can cause drowsiness and somnolence. It is better to advise fewer small fatty meals, limit red meat, stay hydrated, and the patient can use some ginger extract as supplement or boil in water and tea to manage the side effects. But these effects are usually mild, and if you up-titrate the doses slowly, these do not bother the patient much. So when you look at GLP-1 receptor agonists, I guess these are one of the underutilized drugs that we have, and all the guidelines do suggest you start GLP-1 receptor agonists very quickly if you have patients with ASCVD or multiple risk factors for ASCVD, and look at the pathophysiology. Almost more than 60-70% of the pathophysiology of the omnis octard is managed by GLP-1 receptor agonist. Still, we are not using a lot of these drugs. Probably that the reasons are cost and being injectable, but now we have the oral GLP-1 receptor agonist also, but that does not have the cardiovascular outcome data. Favorable cardiovascular outcome data is not there for oral GLP-1 receptor agonist. So you have a type 2 diabetes target patient, uncontrolled on multiple OADs, injectable therapy needs to be started. You can choose dulaglutide. Blood glucose levels are on the higher side, 8 to 10% A1C. Weight gain is a concern, cardiovascular risk is a concern, patient has ASCVD or multiple risk factors for ASCVD. Wants a simple therapy to fit into his or her lifestyle and is motivated to take ownership of long-term health. I guess it is a GLP-1 receptor agonist that has to come up the ladder. So it is moving away from glycemic control to manage type 2 diabetes complications. It's beyond glycemic control. You have to have a more holistic management to look after the micro and the macrovascular complications. A lot of therapies can address vascular risk. You have to have early intensive therapy to get the good glycemic legacy that would drive complications later. GLP-1 receptor agonists are a very good therapy in established ASCVD and even in patients who are obese. And as the first injectable, if there is if there is nothing that only insulin can handle, you have to start, if you want to start an injectable therapy, it has to be a GLP-1 receptor agonist. Once weekly, dulaglutide is easy to use, just one injection per week. Effective glucose lowering agent, has some impact on weight, but counsel your patients when you are starting GLP-1 receptor agonist that these are not weight lowering therapies. These are therapies for managing glycemia and the multiple risk factors associated with diabetes. So if you offer these drugs as weight loss therapies, there may be a rebound because there is dichotomy between glycemic control and weight loss in some patients. Some patients have very good glycemic control, they do not lose weight. Some patients do lose a lot of weight, but the glycemic control does not improve, and some patients benefit most. They have a reduction in glycemia, they have a reduction in weight also. But the benefits are the reduction in cardiovascular events in patients with high-risk ASCVD. But sometimes patient may ask, what is the quantification? How do you say that my ASCVD risk is going to reduce? So you have to counsel them regarding that and probably discuss data that with these drugs, given beyond 1 year, the risk of having cardiovascular events would decrease. Once weekly dulaglutide, patient with CKD, you can use an eGFR of 15. Although in this category of patients, it is difficult to use because these patients may have urinary gastritis at this time, and that may be difficult to manage nausea, vomiting. But it's a simple therapy, and as compared to liraglutide, efficacy almost similar, but it is simple. One injection versus 7 injections per week, I guess makes a lot of sense for a lot of patients. Thank you very much for the patient hearing. Any questions, probably I'll be happy to answer.
Thank you, Dr. Saket, for a very wonderful and very elusive and crisp talk on a wonderful molecule, I would say, because most of the guidelines, though ESD, ADA, have endorsed this GLP-1 analogs for the management of type 2 diabetes as a first choice in patients who are having risk of ASCVD or CKD, in fact. And no other drug would be having, you can use this drug at the eGFR at around 15. In fact, if we talk about HAD inhibitors, which is sometimes talked down, may not use eGFR less than 45. So I think it's a wonderful drug. Yes, semaglutide is also available. So in Indian population, definitely injectable therapy is always a concern. But I think weekly dulaglutide is a wonderful molecule. My co-chairperson would like to say something.
Yeah, I think again, a wonderful presentation. Quick 2 questions. One is, there is a patient who is, let's say, whose HbA1c is not getting controlled with the current therapies, and you want to add an injectable drug, and probably dulaglutide is a preferred. But if somebody is already on insulin, on a basal insulin, what would you do in such a patient where the HbA1c is not getting, it's not coming under control? What would you do? Would you stop insulin and switch to GLP, or would you add GLP-1RA in these patients?
I guess that would depend on the A1C. That would depend on the SMEG profile of the patient. Because if you look at differences between short-acting GLP-1 receptor agonist and long-acting GLP-1 receptor agonist, you will realize that the short-acting GLP-1 receptor agonists, they have more effect on the postprandials, and the long-acting ones have more action on the fastings. So probably you'll have to look at the SMEG profile of your patient, the current A1C and the A1C that you want to achieve for your patient. You can continue insulin. If you want to add a long-acting GLP-1 receptor agonist, probably you'll have to have some dose reduction initially, and then you can up-titrate, because a GLP-1 receptor agonist is going to target many parts of the pathophysiology. So look at the comorbid conditions, look at the SMEG profile, look at the A1C that the patient right now has, look at the A1C that you want to achieve, and that would probably help you in a decision whether you want to withdraw insulin, add a GLP-1 receptor agonist, or continue insulin and add the GLP-1 receptor agonist. That also, I guess, would depend on the other therapies that the patient is taking, because we've got a lot of drugs for managing postprandials. We've got sulfonylureas, we've got gilnides, we've got AGIs, we've got DPP-4 inhibitors to manage postprandials. But we do not have a lot of drugs to manage the fastings. All you have is a metformin, a pioglitazone. SGLT2 to some extent can target the fasting. You've got basal insulin and the long-acting GLP-1 receptor agonist. So you have more drugs to manage postprandials. So if you can manage postprandials with a larger number of drugs, and still the fasting is not controlled, probably it's time, you can continue with both a GLP-1 receptor agonist and an insulin, basal insulin.
So in your practice, what do you feel like contraindication to GLP-1 receptor agonist?
I guess you have to be careful, because if you look at, the most common diabetic dyslipidemia is high triglycerides with low HDL. So whenever you want to start your patient on a GLP-1 receptor agonist, do get a lipid profile done for your patient, because I have had a lot of patients come to me with, TGs of more than 2,000. I have got around 50 odd patients, more than 2,000 triglycerides. Even a triglyceride of more than 500 is a high risk for pancreatitis. So you have to be careful with GLP-1 receptor agonists when you start therapy. Get a lipid profile done. Second is, if the patient has proliferative retinopathy, you have to be careful. Third is the patient, for example, urinary gastritis, lead GFR 15, although it's you can give it at 15 also, you have to be careful. Patients who've got family history of MTC, that is not very common, medullary thyroid carcinomas, you have to be again very careful with GLP-1 receptor agonist.
Dr. Saket, what about gallstones? The patient is having gallstones. Gallstones.
Yes, GLP-1 receptor agonist can increase the incidence of gallbladder sludge and gallbladder stones. So that way also you have to be careful and counsel your patient before starting therapy that this can increase, so be very careful about that.
So any question from the audience, 1 or 2, just short, quick questions. So I think there are questions. We can wind up the session. Dr. Saket, thank you very much for a very excellent session. Thank you.